So, Dr. Zadeh, do you have any advice for dentists just starting out with implant surgeries? How to mitigate risk and any complications?
Sure. I mean, obvious thing is to get proper training in the system you're going to be using. Implant dentistry is more or less like flying a jet plane. You may be a very good pilot, but if you're not trained on a particular jet plane, and those who are in the trade, they know it as being rated for a certain jet, you're not going to be able to fly that jet. So even though you may know implant dentistry, if you're adapting a new system, seek out and learn how to use that system the best possible way. Okay? Yes, all the jets have the engines and the wings and the tail, and they all do the same thing, but as much as two jets are not similar in flying, once you start, using them, the implant systems also have small nuances that you need to learn about that system to do it efficiently. Now, if it's a company or it's a system that does not even offer specific training for them, that's one good reason to stay away from that system. It's not something you buy off the rack and start using it just because you're so good and you have experience in other fields, in other systems. So number one, get enough training for the system. Number two, if it's in the beginning, leave enough time for yourself to do the procedure. And remember that the most important thing right now is for you to avoid complications. And those complications are the complication of infection and bleeding. So take good history. If the patient is on anticoagulants, obviously you want to coordinate that with their physician to make sure they are okay and they are safe. Almost all older people nowadays that are on Plavix or platelet. I don't consider that as a contraindication for surgery, but just know that the surgery is going to be a little messy, because remember, Plavix and aspirin, they act on platelet aggregation. They don't prevent clotting of the blood. Now, platelet aggregation plays a role in stopping hemorrhage from small capillaries. So if you get a needle prick, the bleeding of the needle prick stops by function of platelet aggregation. So if someone is on aspirin and you poke their finger or poke their mucosa with the needle, they'll take longer to stop bleeding. But if you make an incision, you are cutting medium-sized vessels. So there, the mechanism is not platelet aggregation anymore, it's a clotting mechanism. The clotting mechanism is not affected by Plavix and aspirin. The clotting mechanism is affected by coumadin, and now there are newer drugs that work on the clotting mechanism. So you must know what medications they are taking. If they are taking medication that affects clotting, you need to coordinate with their physician and get them to an acceptable rate for surgery. If it's only on platelet, if they can stop it a week before, better. If not, you're just going to have a messy surgery. So get good history, give them good antibiotic coverage, and make sure they take the antibiotic. Just because you give a prescription to a patient does not mean that the patient is buying and using the antibiotic. My advice in the beginning is that give the prescription for the antibiotic on a day before the surgery. Ask the patient to buy it and bring it with them in the surgery. So this way they definitely have it when you're doing the surgery. Then take one of them and give it to the patient at the time of surgery, before you do the surgery. You have started them with antibiotics. Then ask them to continue. This is the most important thing, because a lot of times we do the surgery, give the prescription, and patient leaves with the prescription in their hand. What do you think they're going to do at that time? They're going to go to a pharmacy and stand in line for 5 hours to get their prescription? The other day on a Thursday night, a patient of mine had to wait 5 hours for the prescription to be ready. Now, luckily, this was not a surgical patient, and this was the prescription I had given for surgery a week later. But if the patient had presented that prescription after the surgery, she still had to wait there 5 hours. 5 hours of what? Bleeding, swelling, being tired, being sleepy if they've had sedation, just not happening. So typically what happens is the patient goes home. The next day they're still groggy and all that. The third day they remember, yeah, I was supposed to take some pills and medication too. Oh yeah, this is a prescription. So let me go to the pharmacy. And you know this is exactly what happens, because oftentimes when we do a surgery on a Thursday and a Friday, it's usually Sunday that the pharmacy, if we have messed up something on the prescription, the pharmacist calls us to verify some information. Then you know, okay, is he now getting the prescription? Then the pharmacist says, yeah, he's just dropped it off. So for the new person, even for people who are experienced, if you avoid bleeding and infection, then you've avoided most serious complications after implant placement. Of course, putting the right implant in the right place with the right angle, with enough good bone around it, all of that is there. But none of them will matter if the patient gets infected, and none of them will matter if, God forbid, you have to call the ambulance middle of the night because patient is bleeding and you can't control it.